can see that. And recording is now in progress, which is great. Okay, so welcome to harm reduction and eating disorders. Welcome. My name is Miranda Pecoraro, and I use the pronouns she, her. I'm a social worker and Master of Social Work student at the University of Toronto, and I'm specializing in the field of health and mental health. And I'm completing my practicum at Sheenas place this year. This presentation is actually one of my practicum projects. So I was drawn to completing my practicum at Sheenas place because of my interest in group work, in community-based mental health, in arts-based social work practice, as well as women's health. And I'm honored to have been able to spend my time here as a student, and I'm certainly leaving my practicum with a desire to keep supporting folks experiencing eating disorders and disordered eating. Okay, so I would like to start our webinar today with a land acknowledgement. As we learn and reflect about eating disorders and harm reduction, it's important that we recognize that First Nations, Inuit, and Métis peoples have had their traditional methods of obtaining food and their relationship with the land violently and forcefully altered through settler colonization. As of February 2022, 36 public long-term boil water advisories remain in 29 communities, impacting their ability to prepare and engage with food, and thus impacting physical health, mental well-being. So as a charity providing support to those with body image issues and eating disorders, Sheenas Place acknowledges that First Nations, Métis, and Inuit peoples are often excluded from body image and eating disorder spaces. This is including in research, in treatment, in recovery spaces, and in broader conversations surrounding stigma and support. Harm reduction, in particular, emphasizes the social context in which people live and how this might impact their ability to abstain from harmful health behaviors. And these contexts are fundamentally shaped by the oppression of Indigenous peoples and the colonial, racist, and classist policies that uphold our economic, social, and healthcare systems. So it's our responsibility to work towards decolonizing these spaces and to create supportive environments for all people who desire support. So I'd like to extend an invitation just to take a couple moments to think about your personal relationship with the land that you're on. And I'll pause for a moment here for that reflection. Okay. And I would like to draw your attention towards the resources that I have listed on the slide here. You will have received a copy of the slides in your email invitation to this meeting, as well as I think it might be somewhere in the chat. But when you do get your slides, these underlined pieces of text are clickable, so I encourage you to check out those resources if you would like to. Okay, so I'd like to give you a bit of an overview as to what you can expect over the course of this next hour. First, I'm going to be talking to you a little bit about Sheenas Place and the kind of support offered here. Then moving into defining what eating disorders are and how they might be experienced. Then moving on to harm reduction, and again, defining what that is, its rationale and its practices. And then to sort of consolidate everything, what harm reduction in the context of eating disorders could look like. And there will be a period towards the end of our session today for questions and answers. I think Caitlin had mentioned this, but if you do have a question throughout, feel free to put your question in the chat and we can address those at the end of the session, or if you'd like to take yourself off mute at that time and ask that verbally, you're welcome to do so at that point as well. As for learning objectives, what I'm hoping you can take away with you today is firstly, an ability to identify harm reduction as a philosophy in principles and practices. Also, being able to identify the need for harm reduction in eating disorder and disordered eating support spaces. And lastly here, an ability to identify some contemporary social justice issues in the area of eating disorders. So once again, please feel free to ask questions throughout. I would like to extend a reminder to please take care of yourself throughout the session. This content can bring up some difficult emotions. In particular, I'll be discussing specific eating disorder symptoms, diagnoses, as well as ideas surrounding substance use and suicide. Another mention, I do have references included on the PowerPoint on each slide, as well as a full list at the end if you'd like to do some extra reading or know where I got this information from. And lastly, I would just like to address that I am presenting just one perspective and approach towards eating disorder treatment and recovery. So by all means, please take what feels relevant to you, and you can leave behind or reject what doesn't serve you. Okay, so a little bit about Sheenas Place. Sheenas Place is a community mental health charity that supports people affected by eating disorders. We offer a wide range of professionally facilitated groups and workshops, but this does not include treatment or individual counseling. The kinds of groups that are offered include support groups, skill building groups, body image groups, expressive arts and nutrition groups, as well as educational webinars, as you're aware. Groups are facilitated by registered health or allied health professionals, teachers, and other mental health professionals. So all programs are free of charge, and they're based solely on self-referral, which means that an eating disorder diagnosis or referral is not required. As well, anyone age 17 plus living in Ontario is welcome to register for groups. And we're typically located in a homey, non-clinical and non-institutional house in the Annex in Toronto. However, for this season, groups are currently taking place virtually. If you do have any questions about groups or registration, I'd be happy to try to answer those for you at the end of the presentation to the best of my ability. Okay, so on to defining what eating disorders are. To provide a very basic definition, eating disorders are serious but treatable mental and physical illnesses that affect people of all identities. So meaning all genders, ages, races, religions, abilities, ethnicities, sexual orientations, and all body shapes and sizes. While this doesn't apply to all, individuals diagnosed with eating disorders will often demonstrate a preoccupation with food and body image. However, these preoccupations manifest differently as different behaviors depending on the type of eating disorder that a person experiences. In Canada, eating disorders are diagnosed by mental health professionals or psychologists, and these diagnoses are informed by the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5 for short. So the DSM and its diagnostic criteria are constantly being revised by mental health professionals to more accurately reflect the range and diversity of mental health experiences that exist, and also by whom they're experienced. The most recent version, which is the DSM-5, created in 2013, included revisions to the feeding and eating disorders section with the intention of being more inclusive and comprehensive of a wider range of disordered eating, and as well to aid in the identification of men affected by disordered eating, and also to facilitate the earlier identification of eating disorders. So on the note of diagnoses, receiving a mental health diagnosis can be experienced as validating or empowering for some, but also invalidating or unhelpful to others. Sometimes receiving a diagnosis can be helpful as it enables a person to name their experience and maybe garner a sense of recognition for what they're going through. However, a valid criticism of the DSM is that its development has been built on the foundations of Western patriarchal norms. This meaning that much of the research conducted on mental illness to date has included samples that are severely lacking in diversity. They're mostly composed of thin, white young women and adolescents. And understandings about mental illness have largely been informed by the professional experiences and opinions of white men. And the consequence of this is that mental health diagnoses might just not be compatible to all populations, and they can also be laden with implicit biases. So for example, it has been documented that factors such as racism, sexism, and weight stigma meaning judgments about a person according to their weight by health professionals, impact the accuracy of eating disorder assessments, and therefore the accurate provision of diagnoses. And diagnoses often gatekeep the receipt of mental health services in Canada. So this issue of bias in diagnostic criteria and diagnosis therefore impacts who is more likely to receive appropriate mental health services. So though there might be many people who could stand to benefit from eating disorder support and treatment, many will not receive a diagnosis to be able to go and do so. So as stated, the DSM is being continuously revised to account for the range of disordered eating experiences that exist. And like all other mental illnesses, attempting to create these rigid, definitive categories for what constitutes an eating disorder can often be confusing for folks and can also sometimes lead to the minimization of harmful or problematic behaviors. So, for example, someone might spend a considerable amount of time thinking about food or their body and be negatively emotionally impacted by this. But since this symptom alone does not meet the criteria for an eating disorder, they might assume that this experience is unworthy of being investigated, treated, or healed. So to accurately account for this range, eating disorders and disordered eating are more accurately regarded as symptoms and behaviors that exist along a spectrum that ranges in severity. And thinking about eating disorders along a spectrum of behaviors also calls attention to the ways in which disordered eating is often normalized and condoned in society. So for example, fasting, dieting, and restricting, these are all behaviors that you'll see on the slide that fall within the middle kind of disordered eating part of the spectrum. These are often regarded as healthy eating patterns promoted in the diet and fitness industry, and are thus often seen in individuals who do not meet diagnostic criteria for an eating disorder. I'm just going to pause here for a sip of water. All right, so moving on to a discussion about what causes an eating disorder. They are a result of complex interactions of biological, psychological, and social factors. It's thought that the development, the type, and the duration of an eating disorder is influenced through a combination of predisposing factors. So these might be things like childhood experiences of adversity, family history, genetics, maybe some cultural factors, as well as precipitating or triggering factors, which might be experiencing loss or separation, disruptions in interpersonal relationships, changes to one's environment, or something like a sudden loss of self-esteem. And also perpetuating or maintaining factors. So this could include the cognitive effects of starvation and illness, as well as the cultural approval of disordered eating behaviors. So I'd like to address that while a growing sentiment in the eating disorder community is this notion that eating disorders do not discriminate based on a person's identity, it's imperative that we move beyond this understanding to acknowledge that bodies that are oppressed on the basis of race, sex, gender, class, etc., are significantly more likely to develop an eating disorder or disordered eating, as this directly impacts the way that people feel in their bodies, the additional sources of or heightened stress that they might experience, as well as the ways in which their bodies are treated. Some potential risk factors for the development of eating disorders include things like body dissatisfaction and low self-esteem, engagement in activities that are weight or appearance focused, thinking things like bodybuilding, sports, or performance arts, dieting, experiences of weight stigma, genetics and family history, trauma, a predisposition towards experiencing negative emotions. So that could be the experience of another mental illness at the same time, food insecurity, experiences of oppression and discrimination, as well as those cultural factors that we've sort of touched on. So things like diet culture and beauty standards. So I want to provide some information regarding the prevalence of eating disorders to demonstrate the magnitude and the impact of them. And this will surely justify the importance of really thoughtfully considering the different approaches to treating and supporting those impacted by them, which I think is what we're here to discuss today. So firstly here, findings from the last Canadian Community Health Survey indicate that in 2012, over 113,000 individuals aged 15 and older were living with an eating disorder diagnosed by a health professional. However, based on global prevalence data, an estimated 2.7 million people in Canada have a diagnosable eating disorder. And with these statistics, what should be noted is that these most recent governmental statistics, so the first one I read at the top of the screen, are now about a decade old. And further, keeping in mind that eating disorders are often underdiagnosed because they're often secretive illnesses, disordered eating is normalized in our culture, and weight bias, stigma, and other forms of discrimination impact that number of diagnoses given, and thus the rates of prevalence in the research that we have available. Next, eating disorders are among the deadliest of mental illnesses. This is second only to opioid overdose. So about 26%, so that's just over a quarter of people with eating disorders attempt suicide. The reasons for this being, I just want to elaborate a bit. Aside from the multiple physical and mental health comorbidities associated with eating disorders, for example, the cardiovascular impact as a result of restriction, the physical toll of using diet pills and laxatives or self-induced vomiting, folks with eating disorders or experiences of disordered eating tend to also experience many social impacts, such as under or unemployment, things like social withdrawal and isolation, as well as struggles in interpersonal relationships. And all of this together compounds the lethality of eating disorders. So I'm going to provide some more statistics to illustrate some of the diversity among those who experience eating disorders and disordered eating. They may illustrate the impact of oppression and marginalization on the development of eating disorders to some degree, though they will not provide the complete picture or scope. Because, as noted, research investigating the prevalence of eating disorders among marginalized communities is quite limited. So firstly, among boys and men, so we know that males represent 25%, so again, a quarter of individuals with anorexia nervosa, and they are at a higher risk of dying, in part because they're often diagnosed later. As well, subclinical eating disorder behaviors, things like binging, purging, laxative use, excessive exercise, or fasting for weight loss are nearly as common among males as they are among females. Regarding BIPOC communities, BIPOC meaning Black, Indigenous, and persons of color, it's been documented that Black teenagers are 50% more likely than white teenagers to exhibit bulimic behavior, such as binge eating and purging. And just switching slides here, BIPOC are significantly less likely than white people to have been asked by a doctor about eating disorder symptoms, and are half as likely to be diagnosed or to receive treatment. As well, Black folks are less likely to be diagnosed with anorexia than white people, but might experience the condition for a longer period of time. Among the 2S LGBTQ+ community, some statistics here, 32% of transgender people report using eating disorder behaviors to modify their body without hormones. Gay men are 7 times more likely to report binge eating and 12 times more likely to report purging than heterosexual men. Gay and bisexual boys are significantly more likely to fast, vomit, take laxatives or diet pills to control their weight. And transgender college students report experiencing disordered eating at approximately 4 times the rate of their cisgender classmates. And among persons with disabilities, we know that 20 to 30% of adults with eating disorders also experience neurodivergence, such as autism. Women with physical disabilities are more likely to develop eating disorders. And 3 to 10% of children and young people with eating disorders also have autism. Okay, so I'd like to define now harm reduction. So harm reduction is a term that's typically used in discussions regarding persons experiencing substance use disorders. But it's more broadly defined as a philosophy and an approach to policy, programs, and practices that aims to reduce the health, social, and economic harms associated with harmful health behaviors and people unwilling or unable to stop them. So the purpose of a harm reduction approach is not to completely extinguish a problematic health behavior completely or permanently, but rather to mitigate the possibility and the severity of potential harms. Harm reduction is rooted in several social movements throughout the 1960s to the 80s, including the women's health and reproductive rights movement during the second wave of feminism, as well as in grassroots and activist responses to the HIV and AIDS crisis and hepatitis C infections. And harm reduction has influenced macro, meso, and micro, meso, and macro level interventions. So micro meaning at the interpersonal and individual level, macro meaning among communities and organizations, and at the macro level meaning among governments and in law and policy. To provide an example, harm reduction practices for a person who uses substances at the individual level might mean using substances only when in a controlled environment or in the presence of trusted others. At the organizational level, a shelter might provide overdose prevention kits to their residents. And on a governmental level, a policy might come into place that decriminalizes the use of certain substances. So going forward, I'll be using the language harmful health behavior, and I'm wanting to address that there's no universal definition for what that means. Rather, a harmful health behavior is one that an individual defines as harmful to them because it decreases their quality of life or ability to function in some way that's important to them. So what might be considered harmful to one person might be experienced completely differently by another person. And the way that harm reduction advocates justify this approach, firstly, is that they see that penalizing or reprimanding people who engage in harmful health behaviors does not lead to symptom alleviation in a meaningful, sustainable manner. And it can often lead to further health, social, and economic harms. And this being both for the individual who engages in the behavior and for the communities and the societies in which they live. Harm reduction advocates will argue that reprimanding people for engaging in harmful health behaviors can cast moralistic judgments onto people, which can often induce shame, stigma, and consequently amplify experiences of marginalization. And this may actually drive people to continue to engage in certain behaviors in order to cope with that. In the context of substance use, the requirement that people become abstinent from using drugs is a very common yet high threshold condition for receiving treatment or other services. Harm reduction supporters argue that the exclusive goal of abstinence can often be incompatible with and insensitive to individuals' life circumstances. So in this sense, the expectation of abstinence can be experienced as unrealistic, inaccessible, or ineffective. To provide another example, an individual might be unwilling or unable to refrain from using substances if they have not yet developed alternative coping strategies for managing difficult emotions or experiences of trauma. Harmful health behaviors can serve as an essential survival mechanism in the absence of safer coping strategies. Additionally, harm reduction acknowledges that social inequalities affect both people's vulnerability to engaging in harmful health behaviors and the capacity for effectively dealing with the harm associated with it. So a person might require a considerable amount of time, money, and resources to be able to engage in a treatment program. As I've mentioned, harm reduction involves strategies that can be used at individual, this organizational, community level, and at governmental levels. And by understanding this interplay of personal and systemic issues, the harm reduction philosophy shifts like a person problem into a person and situation problem that considers both individual and these broader social factors that contribute to the development of harmful health behaviors. So I do have a picture slide here. My intention, well, you could probably, if you've been listening, guess or be able to answer the question that's on screen here. My intention for showing this slide is to demonstrate that harm reduction might not be a concept that everyone initially really easily identifies with, since it's often specifically linked to substance use disorders. However, it's a practice that health professionals and society in general actually implement on a regular basis. So for example, people often make the choice to use condoms to reduce their risk of contracting an STI or becoming pregnant. And I think another thing that this slide really illustrates is that risk-taking behavior is a natural part of our world and is inherent to living. Okay, so moving on to how harm reduction may be compatible with this concept of recovery that you often hear about and talk about in mental health recovery spaces. So there's no doubt that abstinence from substance use is 100% effective in preventing harm. However, abstinence-based treatments and support are not 100% effective for all people engaging in substance use. So a harm reduction approach sees that abstinence can be one of many other useful goals that an individual can set in their recovery to reduce harm. In other words, harm reduction and abstinence are not seen as mutually exclusive. Many abstinent-based only treatments and supports will measure recovery in clinical terms. And clinical recovery is often determined by a health professional, and it involves the elimination of all symptoms and all other issues associated with the disorder or harmful health behavior to the degree that it no longer interferes with a person's daily functioning, allowing them to resume to what's considered normal life. This is a medical perspective, and it assumes that those who have recovered are those who have been cured from their illness. Alternatively, the harm reduction perspective is inclusive of several definitions of recovery in addition to clinical recovery. And this recovery does not necessarily require remission of symptoms, nor does it require a return to normal functioning. Rather, it views mental illness or substance use as one aspect of an otherwise whole person. And recovery can mean living a worthwhile, satisfying, and meaningful life in the presence of illness, substance use, or harmful health behavior. According to one's unique definition of recovery, recovery goals can include, and this is a non-exhaustive list, certainly the elimination or reduction of harmful health behaviors or symptoms, but also things like reducing one's health risks or enhancing their well-being and quality of life, restoring hope, participating in meaningful everyday activities, improving one's self-esteem, improving one's interpersonal relationships and connection and engagement to others and in life, as well as things like increased self-determination. So since harm reduction goals can align well within this concept of recovery, it can also be employed alongside the stages of change model, which is a common framework for thinking about one's motivation towards change and the different phases that one encounters when challenging a health behavior. So for example, The action phase for one person might include employing a harm reduction strategy. And for another person, it could be the goal of abstinence from an eating disorder behavior, for example. I'd also like to address some of the principles that guide the harm reduction practice, as well as some specific practices that one could keep in mind. So firstly here, humanism. So this is recognizing that people do things for a reason, and harmful health behaviors provide at least some benefit to the individual. And those benefits need to be assessed and acknowledged in order to understand the balance between them. So in practice, this can look like refraining from making moral judgments about a certain behavior, as judgments normally don't produce positive health outcomes. It can look like communication and treatment decisions being informed by the actual harms posed to the individual, as opposed to knowledge of moral or societal standards. It can also look like providers, care teams, and support systems actively accepting an individual's choices. Next up here, I have pragmatism. This meaning that completely perfect health behaviors are impossible to achieve, and complete abstinence from a health behavior just might not be feasible due to a variety of factors. And what this can look like is abstinence from symptoms or behaviors neither being prioritized nor an assumed goal. As such, a range of supportive approaches are provided to meet an individual's motivation, their circumstances, as well as their ability for change. Next up, there's individualism. So this meaning that every person presents with unique needs, strengths, and receptivity to harm, and therefore requires an individualized approach to care. So what this can look like is refraining from making assumptions and generalizations about a person, their abilities, and the function of their behaviors. It looks like starting where the person is at. As well, not promoting a universal messaging or intervention plan for all individuals seeking care, for an example, at, say, the organizational level. Next up is autonomy. So this meaning individuals are responsible for their choices and health behaviors. Simultaneously, individuals have the right to make harmful health behaviors without running the risk of being turned away or terminated from care. So those service providers might offer suggestions and education regarding treatment options. Individuals ultimately make their own choices about medications, treatment, and health behaviors to the best of their abilities, beliefs, and priorities. And what this can look like in practice are partnerships that are centered on collaboration, reciprocal learning, and person-centered care. And lastly here, I have incrementalism, meaning that any positive change is a step towards improved health. And at the same time, change is nonlinear and takes time. So what this looks like might be a celebration of positive movement, while also normalizing plateaus and setbacks. It could look like interpreting backwards movement as an opportunity to develop further understanding of the impact of harmful health choices, as well as about a person's resilience. Okay, so to begin to justify the use of harm reduction practices in the context of eating disorders, I will draw out some of the common features of both substance use disorders and eating disorders. It's a common question whether eating disorders function as some form of addiction. And while eating disorders are not addictions in and of themselves, those who experience substance use disorders may share similar behavioral, psychological, and social experiences. Something to keep in mind here is that the current prevalence of any co-occurring substance use disorder among those experiencing eating disorders has been reported at 21.9%. In addition, many folks with binge eating disorder in particular strongly identify with the cycle or experience of addiction. So firstly, in this psychological domain, our brains have special reward centers that are stimulated by certain behaviors, such as being praised or taken care of or loved. And reward centers can also be activated through harmful health behaviors, such as the use of substances or by restricting, binging, purging, overexercising, etc. So stimulation of the reward center of the brain works to block undesirable feelings and emotions. And this interaction can lead to an addictive cycle. Because when the brain is saturated with these feel-good neurotransmitters, as a result of this stimulation and unpleasant feelings are blocked, the stimulus, which might be substances or an eating disorder behavior, can become increasingly desired. And it's through this cycle, through this mechanism, that addiction and dependency on eating disorder behaviors can be created. On the behavioral level, the manner in which individuals experiencing eating disorders relentlessly pursue certain behaviors despite knowledge of the negative physical, emotional, and social consequences they bring also parallels features of addictive disorders. Further, individuals who experience eating disorders, they might behave similarly to those with substance use disorders in that they might narrow their behavior or their behavioral repertoire so that weight loss, restriction, food consumption, or exercise interfere with all other daily activities. And in both experiences, individuals may experience an unrelenting drive to pursue a harmful health behavior. In addition, individuals experiencing eating disorders often engage in symptoms to regulate dysphoric moods in a similar manner to those who use substances. And when individuals reduce or are forced to reduce their engagement in eating disorder behaviors, anxiety increases in a similar manner to when anxiety has been reported during periods of drug abstinence or withdrawal. Lastly, here is the social domain, which I think we've sort of been touching on throughout the webinar. While it should be noted that a significant domain in which substance use disorders and eating disorders diverge is that disordered eating is often promoted and condoned as healthy in the diet and fitness industry, as well as in media and popular discourse. It's also not uncommon for folks with eating disorders, specifically women, to receive positive external reinforcement or validation for engaging in eating disorder symptoms. So I found this quote in my research that I thought seemed to tie together these threads of harm reduction, addiction, and eating disorders. And I will read this out. So eating disorders and substance use disorders have much in common. Physically stereotyped to the detriment of all involved, alternately stigmatized and romanticized depending on who's doing them, increasingly diverse, even if media coverage and clinical research focus on the subgroup with the highest mortality rate, fictionalized as linear progression stories where people hit rock bottom and then get better. They're both usually okay to disclose as something from your past that you've recovered from, but make people super uncomfortable if you say you do this stuff currently and have no immediate plans to stop. So from this biopsychosocial standpoint, the powerful dependency on eating disorder behaviors that often occur can make it extremely difficult to commit to abstinence. So I want to touch on now what eating disorder recovery tends to be regarded as or thought of in eating disorder support spaces. So symptom-free recovery is often the explicit goal of intensive eating disorder treatment programs. That is like a clinical definition of recovery is used. And this medical conceptualization of eating disorders and what constitutes recovery is sometimes also promoted in informal eating disorder spaces, so things like online support groups or peer support models. And it's consequently sometimes internalized by the people who experience them. And while many people with eating disorders make a recovery in the sense that they're entirely asymptomatic, for some, there might be a low chance of achieving an entirely symptom-free recovery, and this is for a variety of reasons. Firstly, you'll consider that one cannot abstain from eating disorder behaviors in a similar manner to the way that those with substance use disorders can abstain from substances. So that is, food and movement in some form are essential to human life. Additionally, there are significant deficits with regard to the available treatment and support options for those experiencing eating disorders. And when one's support resources are so limited, the expectation of abstinence might be unrealistic. To detail a bit more here, there are extremely limited services and support for people experiencing eating disorders and extensive wait lists for publicly funded treatment programs. Of the existing treatment and supports available, there is often a lack of diversity in terms of practitioner identity, or a lack of services that center on identity or experiences of marginalization that contribute to the development of eating disorders. As well, there are additional financial and healthcare barriers experienced by marginalized communities, which might impact one's ability to adhere to abstinence. So support from family and broader society is often needed to recover, and it's not always available. And as you'll recall from earlier, members of marginalized groups are also less likely to receive an eating disorder diagnosis, which significantly impacts one's ability to access treatment in Canada. Alternatively, harm reduction practices are very accessible and affordable, can serve as an entry point for one's recovery or seeking care, and can be both integrated into professional treatment or done independently. In addition, while abstinence and symptom alleviation are often touted as the singular goal of eating disorder recovery, eating disorder treatment service users have expressed multiple definitions of recovery in the literature. Some of this has included, once again, certainly the cessation of eating disorder symptoms, but also things like the absence of disordered thinking patterns, or an ability to tolerate difficult emotions, or a resolution of body image or self-esteem deficits, the ability to develop and maintain loving and meaningful relationships with others, general overall functioning, as well as improvement in well-being and quality of life. So it's for these reasons that I'm suggesting that harm reduction in the context of eating disorders can be ethically defensible. An ethically gray area of harm reduction practice in the context of eating disorders is this notion of client autonomy. So people experiencing eating disorders are often in denial about the seriousness of their own illness, and this is part of the psychopathology of eating disorders. So involuntary hospital admissions and treatment that use practices like force feeding, for example, are a very common practice, and it might be initially responsible for symptom-free recovery. Many people with eating disorders have subsequently said that they were appreciative for receiving this care against their wishes at the time. So in discussions about treatment goals, it can make it kind of difficult to determine if a person is truly making an autonomous decision about their care and their quality of life, should they choose to continue to engage in symptoms with the harm reduction practice, or whether in fact their decision would be different if they were in a different cognitive state. So I don't have an answer for this. These circumstances must be considered on an individual basis. And you'll recall that individualism is one of the core tenets of harm reduction practice. You might consider that some research suggests that the long-term outcome of people treated for eating disorders on an involuntary basis may be worse than those who are treated on a voluntary basis. As well, people are more likely to trust treatment providers and be willing to seek care if they feel that their personal goals, their wishes, and their perspectives are being respected. And one way of providing this person-centered care is through a harm reduction lens. So again, what do eating disorder harm reduction practices look like? It might involve acknowledging and accepting that the person will continue to binge, purge, exercise, etc., and involves trying to mitigate the potential harms that can result from this behavior. It also might involve encouraging the person to maintain other certain behaviors in order to achieve a parallel goal, such as improving their quality of life. It also involves recognizing the function of eating disorder behaviors. So engaging in symptoms often provides folks with a sense of control, relief, comfort, and familiarity. So eating disorder behaviors are often essential coping strategies for dealing with difficult emotions, stressful life circumstances or events, and in dealing with trauma. On a macro or sort of systemic level, it could involve addressing the larger social inequalities that contribute to the harm associated with eating disorders and symptoms. So for example, it could involve increasing access and funding for services at all levels of care so that folks have more choices open to them and can remain safe. Harm reduction, it might be a counterintuitive approach to many eating disorder programs and philosophies, which typically try to normalize eating patterns, encourage people to consume various foods, encourage them to achieve a particular weight, or require them to be asymptomatic. So a harm reduction approach to working within this system might include providing people with the opportunity to receive respite from their behaviors by being an inpatient for a few weeks, with the purpose of achieving temporary medical stabilization without receiving intensive treatment with the end goal of abstinence. As I've mentioned, though, specific harm reduction practices for eating disorders will vary from person to person, depending on their disorder, the symptoms they experience, the harm they associate with those symptoms or behaviors, as well as any consultations with a healthcare or medical professional. So I want to draw your attention to the two resources I have listed on the screen here. The first one here is more so oriented towards service providers. And the second one here, I would say more so accessible to everyone. I am going to provide some generic examples listed in this resource, just because I don't see these practices being circulated often online or something that's easily accessible. So some generic examples include for binging. It might involve eating slower, as binging is often done in a dissociated state, taking short walks afterwards to aid in digestion, adding a hot compress to one's stomach if they experience pain while digesting, exploring eating until fullness, rather to the point of extreme pain when having large meals. Some examples for restricting would be perhaps taking multivitamins and supplements, to keep bones strong, exploring engagement in resistance-based exercise to the extent that one's body can safely handle. Avoiding exercise that might involve motions that bend or twist the spine, or contact sports, or those that involve a risk of injury or falling. As well, it might include incorporating specific safe foods into baseline nutrition goals. For purging, using a hand as opposed to a foreign object to prevent against choking. And if scarring is a concern, alternating hands. Watching for blood, as this might signify a tear in the esophagus or stomach lining. Waiting at least an hour afterwards to brush one's teeth or consume any sugary or acidic foods. As well, mixing baking soda with water to rinse and spit in the meantime is a practice that's sometimes used. Drinking Pedialyte or Gatorade to restore electrolytes and taking small sips when doing so. And using enamel building toothpaste and a soft toothbrush as a sort of ongoing sort of care. And also here for over-exercising. So this could look like stretching and warming up, working out with another person, incorporating slower movements like walking or swimming. If a person is exercising alone, always keeping their phone on them in case of an emergency, or listening to slower paced music or practicing, say, mindfulness practices while exercising. So I do have some resources listed at the end of my slides here. I think I mentioned this before, but on your copy, these will show up as clickable links. So if you'd like to, if you're looking for information about different support services or treatment options, we have some hospital-based treatment programs, private options, as well as some support groups. And yeah. That is about it for the presentation. I'm going to stop sharing my screen here. I'll just give you a little preview of the references. They are there. And yeah, we can pause here for some questions and answer. Well, hopefully I'll have some answers, but some questions. Maybe we could start out with what has appeared in the chat.
Awesome. Thank you so much, Miranda. That was so informative. And we do have a few minutes left for questions. I'll start with one in the chat, and then we'll go to the person whose hand is raised, and then we can come back to the chat. So one question here says, what does patient engagement in eating disorder or harm reduction spaces look like to you?
Patient engagement. I think, to me, what that sounds like to me is having a person, is this idea of client or patient-driven care. So ensuring that a person is involved in all levels of their treatment or the support that they're receiving, and that their wishes, their boundaries, and their priorities are being taken into account.
Agreed. Thanks, Miranda. Okay, so Joanna's hand is raised if you'd like to ask next.
Hi, sorry, my lighting is horrible. Thank you so much. That was really great and very interesting. My question is more of a clarification around the difference between addiction and eating disorder in regards to harm reduction. What I've learned is that you kind of do have to work through your symptoms through eating disorder recovery, which makes sense. That's exactly what harm reduction is, because you can't go abstinence with food or anything like that. But with addictions, it's different in that way, because you should be going abstinent from your addiction. So what would harm reduction, I was a little bit confused in exactly how that looks with addiction. Is it kind of the same way with eating disorders, where you have to work through your symptoms and then recover from that and then work through your symptoms again? Or is that more seen as like relapsing?
Yeah, and I think, again, this is just my perspective, but I don't think that recovery is experienced universally or the same way for each and every person. For people who do experience substance use challenges, it's not always the case that those who achieve recovery are achieving it in the sense that they're no longer using that substance. For them, it could mean that they're using the substance in a way that prevents or mitigates the harms associated with it. So it really depends on how that individual is defining recovery for them, and often that can just mean improving their quality of life in a significant way that's meaningful to them. Did that answer your question?
Kind of. I was thinking, for example, I was thinking more for like opioid use. So if someone struggles with that, I don't know, like working through, let's say like you're reducing the harm as I don't know exactly how that would look, because is it just kind of, you're using it less often? Is that more of like working through recovery in a slower way with harm reduction?
Yeah, and I apologize because I don't have like an answer necessarily. Like I said, it's an individualized sort of process. Certainly, it could mean reducing the amount of times that they're using a substance, the amount of the substance that's consumed. It could mean swapping out the substance with an alternative one that mitigates the harm that they experience a bit more. Caitlin, do you have anything to add to this answer?
Just that I think, in the context of this very short webinar that was focused on more eating disorders and harm reduction, there's a lot that we haven't been able to explore in the context of substance use specifically. So I would just encourage anyone who's interested in learning more about substance use and harm reduction to look into that, because there is quite a bit of information out there, certainly more than we can provide here today.
Thank you.
Okay.
Thank you for your question.
Oh, sorry, Miranda. Okay, so we have a few more. We'll see how many we can get to. There's one question here in the chat that says, do you see a harm reduction space in queer communities that tackles both drug abuse, for example, chemsex, etc., and disordered eating? And what would that look like to you?
So the first part of that question is, do I see it? To be transparent, in doing this research about harm reduction in the context of eating disorders, I chose this topic because I saw that there was a gap on this topic out there on the internet in the world. I didn't actually find any sort of outreach presentation or educational resource that explicitly addressed this intersection. So in my professional experience thus far, I have not seen a lot of crossover that explicitly addresses eating disorders with the specific lens of harm reduction, though what is common, particularly in like peer support models or support-based, like a group-based support or peer support, is that while harm reduction is not explicitly named, things like person-supported or person-centered care, or not imposing like a universal sort of definition of recovery, that is something that is maintained often in those spaces. So while I have not seen it very explicitly, I do think it's there. And there was a second part of that question, if you don't mind if I could get that again.
Just what would that look like to you, a world in which these kind of two things are combined, like harm reduction in queer communities that's tackling drug use and disordered eating together? Which I think you kind of answered in terms of what you've seen. Something I can quickly add to that is that I think in many cases, these issues are unfortunately addressed separately, kind of in silos. We often will see substance use in general and eating disorders as being very separate, whether that's in the queer community or queer communities pluralized, or in like in other parts of our community. So I think there's not enough support or treatment that addresses these things together in general, unfortunately, even though that's what a lot of the research recommends. I see another hand raised if we want to go to Cody, and then this might be our last question. We'll see if we can squeeze in one more.
Hi, I was just wondering, because in a lot of conversations around harm reduction, and especially like talking about the questions that were just mentioned around like drug abuse in like queer communities, or like just like the way that marginalized communities tend to like use coping mechanisms that are classified as maladaptive. Like I was wondering if there was any reason why eating disorders weren't like described as like coping mechanism, or like if there's any kind of like background or like the way that the research was framed, because that's like usually the way that I've seen it portrayed, is just like talking about eating disorders or drug abuse as like a coping mechanism. And so like centering people's agency and control and using harm reduction as a way to meet them where they're at has been like a lot of discussions around it. So I was just wondering if there was any reason why it wasn't used.
Yeah, absolutely. I apologize if this wasn't centered so much, maybe in the presentation slides, but certainly eating disorder behaviors function in a very similar way, in that they're essential coping strategies in the absence of other healthier strategies for regulating, dysphoric moods or other distressing sort of experiences. So they're very, very common in that sense. And I apologize if I didn't emphasize that enough, but that's certainly at the forefront of mind when thinking about harm reduction practice and in the context of eating disorders.
Thanks, Miranda. Okay, so we are unfortunately out of time. I see that there are a couple of questions in the chat that we haven't addressed. I will share my email in the chat. So if anyone does want to email a question, we can do our best to share extra resources for that. One last thing that we'll share in the chat is a link to an anonymous feedback form. We would love your feedback about this webinar. As I mentioned, it is anonymous, so anything that you liked, anything that you think could be improved in the future would be very much appreciated. So thank you so much, everyone, for coming today. And please reach out if you have any questions or concerns going forward.
Thank you, everyone. Thank you for being here and for participating in this conversation.